this is surgery high yields. I couldn't fit everything obviously into this one thing because surgery is overlapping with it overlaps with IM quite a bit, and they're mostly going to ask you to identify surgery-related causes because they won't ask you in-depth treatment of surgery-related causes. So, like for example, like, oh, if you get anything surgical, um, they're not going to ask you like a lot about the surgery treatment options. They're going to ask you about the pathophysiology and is what it's going to delve a little bit into the IM part of it. So having said that, let's get started. Something that is really important, they love to ask, is fat embolism syndrome. Now you need to know when to recognize this because the question might seem a bit vague when they introduce fat embolism. For example, the question can be like, oh, you have a patient, say he's 36 years old. He is he just got a surgery for an ACL tear or something like that. So, and then in the day after his surgery, he starts getting the clinical triad, which is written over here, of respiratory distress. But they're gonna describe it like he starts having um, anything related to respiratory distress. It can even be like a really severe cough, difficulty in breathing. And then he has confusion, and then you also, on examination, you see a rash, right? So that should point you straight towards fat embolism syndrome. And then, like I said, like in surgery, they're probably not going to ask you a lot about the treatment. They will if you choose a surgical branch and you're going for your you know, in your residency, your exam. But in the MCCQE, very rarely will they ask you really in-depth treatment. You just have to know what what causes it and stuff based around that. So what they might ask you is that A, what do you think it is? And fat embolism syndrome will be one of it. Second would be like, what would you do? And they can give you options like glucocorticoids. Then it can be like give him fluids. It can be like explore the wound. Things that kind of make sense, but they're not the right answer necessarily. Like you think that, oh yeah, sure, I'm gonna start fluids and let's see what happens. What you need to do is you need to make sure that you know what they're talking about. So if you're talking about fat embolism syndrome, you need to do mechanical ventilation first to treat this respiratory distress, and you need to immobilize the fracture. So for example, like if you have somebody who has had a fracture, and sometimes even like really bad fractures, they don't go to the hospital. For example, in Canada, the wait times are too long or something like that. And then he comes with this triad, you're probably looking at a fat embolism syndrome. So based on the case, as long as you know what you're talking about and you know the basics of treatment, you are on the right path to selecting the right answer. Um, and important is to distinguish this from amniotic fluid embolism. Obviously, the easiest way to distinguish is that this will be a woman who is either pregnant or, especially the classical one is right after delivery, a patient will present with this sort of scenario. So it is seen especially when the patient has waited quite a long time to deliver, and you'll see signs of shock, DIC, coma, or seizures. So, for example, your question can be a postpartum woman collapsed immediately after delivery, right? What do you do? And like I said, over here, you just give supportive measures, right? You do mechanical ventilation if she's having respiratory problems. You can even do transfusion. You have to look obviously at her blood type to rule out and see if she was given ROGAM and all of that in her previous pregnancy. But I just wanted to put this there to distinguish between fat embolism and amniotic fluid embolism. They probably won't ask you a question on amniotic fluid embolism because they have to say that's the patient is pregnant, right? This one, it's kind of tricky to honestly read this out because the triad that you see over here, it's it's like pretty vague in a sort of sense. Like it could be anything. Like, oh, you're looking at a patient with confusion. You're thinking of so many different things, right? Like delirium or like especially post-op delirium. Then you're looking at rash and you're like, oh my gosh, is this like an allergic reaction? Is this an infection? So very important is to know to identify this because I think it's very easy to miss. I've missed it on some of my practice tests too. So that was uh, embolism. Next thing I want to touch upon is compartment syndrome. I want to touch upon like things that are easily missed in and conceptual things in this class. Obviously, surgery has quite a lot of things that you just need to rote learn, like just like learn up stuff. I'm not really going to go over that. I'm going to go over stuff that I think is easily missed, and you might think, oh, it's something else, but like it's you need to like weed it out of like, oh, these are the symptoms, so I need to say that this is what it is. So the next one that's kind of like in this pattern is compartment syndrome. So again, you'll see somebody with a like a very typical scenario is somebody comes in with crush injury or long bone fracture. So you take the same guy that we took for fat embolism, same patient. If he comes with a long bone fracture, like for example, this guy lives in rural Saskatchewan, and he has to travel very, very far for a tertiary hospital. He fractures his femur, but he doesn't, or his humerus, and he doesn't really do anything. He just ties it up in a cast himself. And then after some time, he has severe pain if he moves his hand even or arm or leg, depending on which bone it is, a little bit intense pain. And then he decides to come to the hospital, right? So in this scenario, you need to know that it's acute compartment syndrome. If he doesn't have, confusion, particular rashes, then it's probably not fat embolism. Obviously, it's not only in long bone fractures, it can be seen with a lot of things. Um, Especially, I want to draw your attention to massive fluid resuscitation. Now, um, the reason I wanted to draw your attention here is that massive fluid resuscitation can be seen in a lot of cases, right? You have a patient with with say X disease and you want to attach a lot of fluids to him. For example, if you have a patient with acute pancreatitis, and that's like the classic case where you want to give him a lot of fluids, right? Can anybody tell me what that might cause with relation to acute compartment syndrome? There's another syndrome that is very closely related to this that you might see in a patient where he's presenting with acute pancreatitis and you've given him a lot of fluids, and all of a sudden this patient has acute abdominal pain. What do you think you would be looking for? It's like almost the exact same as acute compartment syndrome, but this is of the extremity. Does anybody have any clue at all? So, um, so we'll get to that. Maybe if I give you a little time, you'll get it. Acute compartment syndrome of the extremity. It's the 5 Ps. You guys already know this. I'm sure you've already studied it: pain, pallor, pulsiosis, paresthesia, paralysis. So, if the patient has a crush injury and he presents with all of these things, so for example, typically seen in the leg, in the lower part of the leg, you have extreme pain. You can't feel distal pulses. It looks unusually pale, and there could be, um, difference in how the pinprick sensation is there versus on the other leg, especially. This can also come in your neck, guys. So compartment syndrome, they can give you emergencies in your neck. I think it's a really common misconception that you can't get emergencies in your neck, and that's just wrong because I think for the most part, you get like almost 50% of your cases will be emergencies. So you have to think quick in that sense. And that's what they're testing. Like I said in my previous classes with you guys, they're not testing your knowledge in an act, they're testing how you act. So we'll get to that later. So the thing that I was talking about with the acute pancreatitis guy who has been massively fluid resuscitated is just go to the next slide, is abdominal compartment syndrome. So that is something that is basically like acute compartment syndrome of the extremities, but it's only in the abdomen. And they could very easily ask you this. And the reason I included this in my presentation was because it's, again, it's kind of vague. Like, okay, you have abdominal pain, and this guy has acute pancreatitis. Is this pain because of the acute pancreatitis? Or what is it because of? So basically, what's happening over here is because of like I said, the intra-abdominal third spacing of fluid, the edema, and the ileus is causing the abdominal compartment syndrome. So because the abdomen is it's sort of distended, it's pushing on your IVC and decreasing preload, and that causes severe hypotension, and your cardiac output would be decreased quite a bit. And so let's see what causes this. So massive fluid resuscitation will cause it. For example, you have a guy with acute pancreatitis, you want to fluid resuscitate him, or a guy with trauma, he's lost a lot of blood, or sepsis, and obviously pancreatitis too. So all of these will cause anything that will cause a lot of fluid to go to the intra-abdomen, which will cause edema, ileus, and third spacing of fluid, will cause acute abdominal compartment syndrome. And according to me, I think this is pretty hard to weed out because you're thinking of so many things. It's most likely going to be a complicated patient because to get to acute abdominal compartment syndrome, it has to be not an easy case, but you guys are gonna know this because we've talked about it right now. Okay, so if this comes on your exam, you have like a slightly complicated patient and he's presenting with all of these things, you just have to know, like, okay, the abdomen is getting distended, the venous compression is happening. Like I said, it's going to push on all of especially the IVC. Cardiac preload is going to decrease as a result, and venous return is also going to decrease, which will cause hypertension. And because of the hypertension, the heart is going to be like, oh my gosh, like I'm getting less preload. I'm like the body is hypertensive. So what is it going to do? It's going to be tachycardic. It's going to like increase the heart rate because it's going to try very desperately to increase the cardiac output. But as a result, you're going to see hypertension, tachycardia, decrease venous return, and obviously decrease urine output as a result of the decrease in all of the intra-abdominal organ perfusion. So again, don't get confused if it's a complicated patient like this. You just have to figure out what's happening to the patient. And yeah, so now you guys will know if you get this case. So that's done with. Another thing that I want to touch upon, which can be a little bit confusing, according to me, is the difference between small bowel obstruction and ileus itself. I think ileus itself is pretty complicated, and it's very, very likely that you guys are going to get a question on ileus because a lot of things can cause it, and you guys need to know what can cause ileus. So I know I said over here already, recent surgery, you guys already know this, recent surgery, metabolic causes, and medication induced. Can anybody tell me if you know any other causes of ileus or small bowel obstruction, really? They're kind of the same, but I'm going to highlight some differences. Do you guys know any other cause of an ileus or any other type of ileus? There's so many types, right? Do you guys know any other type at all?
Um, if it's mechanical, volvulus.
Yeah, yeah. There's volvulus, correct. And any other type at all, you guys? So we'll come to it. Don't worry, I won't leave you hanging. But it's just activate your brain cells a little bit. Okay, let's just continue. If you guys um think of something, you can like raise your hands or something. I don't know if I can see the chat right now because I'm sharing my screen. Oh, there's somebody in the chat. Okay. Oh yeah, hyperkalemia. Yes, yes. So that would be here. Very good. Um, and yeah, okay. So we'll just go forward. So the main difference between small bowel obstruction and ileus is basically um this. I wanted to put like a small circle over there, but like my PowerPoint presentation skills are still not that great. um, but yeah, ileus means reduced bowel sounds. Small bowel, and the reason is basically the pathophysiology of this. Ileus means that there's no structural deficit in your small bowel, but it is not moving. So stuff is not moving because of the small bowel. Small bowel obstruction means that your bowels are fine, but there's something obstructing it, right? So which means your bowels are going to be like, okay, I'm trying really hard, but there's something obstructing it. So I'm going to try even harder. Okay. So that will cause the increased bowel sound. So if you put your stethoscope to the patient's tummy, it'll be like you hear a lot of noise. And that means you're looking at small bowel obstruction. Ileus, you're putting your stethoscope to your patient's tummy and you're not hearing anything. And that will probably mean that the muscle in the small bowel is somehow it's not doing its work. But there's no structural change in the small bowel, right? So and over here it says that these are all UWorld tables. If you guys, I don't know if you guys already knew that. I use UWorld step 2 a lot in my MCCQE preparation, and so I'm using them here. In small bowel obstruction, the large bowel won't really be dilated, and ileus it will be. But the main difference again is this, and also the etiology of it. So let's discuss a little bit more about the causes of ileus and stuff like that. So I don't know who it was who said hypokalemia. So Irving, I hope I'm saying your name right. So that would be paralytic ileus, which is over here. So I'm gonna try and zoom in. There are other types of ileus, like gallstone ileus. I don't know if it's Tiffany who said that there was volvulus, that's also there. And then in the end, I want to discuss a little bit about meconium ileus, which is seen in the pediatric population. So first of all, most common would be paralytic ileus, which is the hypokalemia guy. So this is basically you have a failure of peristaltic waves in the intestine. And this can be caused by a lot of things. Hypokalemia is the number one cause. Um, and the treatment for this is so easy. Like you just correct what's wrong. So if you have hypokalemia, you like correct that. If you have uremia, you correct that. And again, that's tying into IM a little bit. So mostly in your MCCQE, like I said, you will have a surgery thing and it will tie into IM. So you need to be both and good. A lot of people just completely disregard surgery, and as a result, you lose out on a lot of stuff. So it can also be seen in peritonitis, typhoid, and after a major abdominal operation. So if I have to give you a case, like to ask you in a question, it'll be like Mrs. Brown is a 58-year-old. She comes in for a surgery. Let's say she has ischemia, and the surgery went off fine, but in a couple of hours post-op, let's say 24 hours post-op, she has um, severe abdominal pain. You put the stethoscope to her tummy, you can't hear anything. Classic paralytic ileus, right? Um, and um, if you have paralysis of the colon, it's called Oligive syndrome. Of the stomach is called it's just acute gastric dilation, and of the small intestine is called paralytic ileus. So a lot of things can cause it. You just have to treat what's wrong. So there's not just one treatment of paralytic ileus. You just have to see what is causing it. And it'll be like a couple of days after post-op, which will be like like Mrs. Brown, or she's recovering post-op, and then suddenly she'll have all of these symptoms. She'll also have vomiting, constipation, And like I said, auscultation would be dead silent. There can also be a tinkling sound, but I mean, that's not really classic. Basically, if you see that it's not really, you're not hearing anything, it's going to be paralytic alias. Okay. Um, all of this, they probably won't ask you like the tympanic abdomen, pseudo shifting dullness. That's kind of like technical. They normally, what I've seen is that they don't give you a lot of technical stuff. They just give you like a normal patient, and you're supposed to know what it is. So, like I said, Mrs. Brown in this case. Um, and we'll get to the x-rays. I have a lot of x-rays in this presentation because they do ask you x-rays. And what I've noticed is that a lot of the times the x-rays they and the imaging that they ask is surgery related. And then they'll ask you something like etiology based or something. The next one I want to talk about is gallstone ileus. Again, really, really simple, but you just have to know how it happens, right? So let's say another patient, I don't know, Mrs. Smith. She'll have repeated cholecystitis. Maybe they'll even give you a patient with the fat fertile 4D type situation. And so she has a lot of gallstones basically, and repeated cholecystitis, which basically means a lot of stones. And if the stone, very simple, I'm going to spend like less than 30 seconds on this. The stone passes down, you get like a cholecystoenteric fistula, which means that there's a connection between the gallstone and your intestine. So the gallstones can pass easily into the intestine. You have a simple mechanical obstruction, right? And you just basically need to know that this thing can happen, because if you get, like, it's easy now because I'm saying it, but if you get a patient in your question, like Mrs. Smith, she has repeated cholecystitis, and then and then they give you a scenario of like ileus or any other sort of obstruction, your mind will automatically go to the gallstone more than the ileum, I feel. So you just have to know that, oh, if she has repeated cholecystitis, that probably means that because of the repeated inflammation, there's going to be a cholecystoenteric fistula that's forming, and the gallstones are actually causing the mechanical obstruction. And what you have to do is just treat the main cause. So if she's a candidate for surgery, remove the gallbladder, make sure that all of the gallstones have passed. And yeah, they won't really go into major details about the treatment, but you just have to know this. And a lot of people don't. A lot of people will think that, oh, it's something related to gallbladder, but it's actually the gallbladder stones obstructing the small bowel. Now, this is something that I have been asked so many times on my practice exams and stuff, and it's really, really important for you guys to know the difference between the Hirschsprung's and the meconium alias. So I really like this table. I've visited it like hundreds of times. Very, very important for you guys to know. They love asking. In my previous classes, I did say that the MCCQE doesn't really focus as much on syndromes as like the USMLE does. Like they want to ask you like a really complicated syndrome, but they do want you to know like basic syndromes like Down syndrome. They love asking you the connection between Hirschsprung's disease and Down syndrome. So basically, what happens in Down syndrome is that they are more likely to get Hirschsprung's disease. The level of obstruction is in the rectosigmoid, and the squirt sign is positive. So what the squirt sign is that basically when you're trying to relieve the gas because of the obstruction, there will be like an explosion of like gas and fecal particles. Okay, because it's in the rectosigmoid, because it's closer to the rectum itself, there'll be like, there's increased pressure over there, there'll be the squirt sign, which will be positive. In meconium ileus, it's seen more so in cystic fibrosis. So they'll give you probably a typical cystic fibrosis pediatric patient, and then they'll probably give you, an iliatic sort of patient. They might even give you an X-ray with the multiple fluid levels. You just have to know cystic fibrosis is related to meconium ileus, and I'm probably looking at meconium ileus. And they might even make it easy for you and say the baby hasn't passed meconium, like the first poo, he hasn't past anything. So they can make it really easy for you. They can make it slightly more difficult, like just give you like a cystic fibrosis looking guy, um, and say like, he does the classic crawl of the cystic fibrosis, which is called like the he's just his legs aren't functioning really well. But if they say that, and they could give you just an X-ray, no other information, which they do love doing, like the MCCQE guys, they don't love giving you a lot of information, like the steps do. The steps like giving you like a whole paragraph. MCCQE is probably just one or two lines, and you just have to be like, you just have to know this. Meconium is seen in cystic fibrosis, and the meconium consistency is inspissated, which basically means it's really, really thick. And there won't be any squirt sign there. So again, really easy, but really, really important for you guys to know. Like I said, I wanted to put a lot of x-rays because they do like asking this. So this is the multiple fluid levels over here. You can see over here, seen small bowel obstruction. Another thing that's seen classically is this dilated small bowel. So probably the obstruction is somewhere like over here, I want to say. You'll also see valvulae conviventes. So if you see this sort of thing, you're looking at like an obstruction probably over here or something like that. And multiple fluid levels is also very common. It depends on what the patient presents with. You can present with either or. Just don't be confused. Like, don't be like, what am I looking at? Like, is the intestines going up into the lungs or something? It can, right? Depending on like how bad the obstruction is. It can be pretty bad. And even over here, it's like looking like it's kind of intruding into the lung area, but that's normally how it presents. And it's looking like both of these are pediatric x-rays too. So yeah, don't get confused. Know what you're looking for. Okay. Okay, let's have a question, see if you guys can answer this. This is a completely different topic. So if you have a hyperextension injury in an elderly patient with pre-existing degenerative changes in the cervical spine, what sort of injury are you looking at? So they actually like doing this in the MCCQE. They will give you the type of injury or the type of disease causing a certain deficit in the spinal region, and you have to know what it is. So this is a very classic example of that. So if you guys have any sort of idea, if you have like a question like this, say 90-year-old Mr. Smith presents with hyperextension injury. He already has some sort of degenerative changes. What do you think, which area do you think will be affected if it's hyperextension like this? Is it going to be the front part? Is it going to be the back? Is it going to be like anterior, posterior? Is it going to be in the middle? Any idea at all? For example, like, oh, we have somebody in the chat. The back. Yeah. So it's going to be, so let me see. There's like this thing over here. So you guys have to know what sort of injury basically causes what kind of deficit. So the back is correct. Like it's probably going to be a back injury, but can also be something called central cord syndrome. So if you see over here hyperextension injury, it's seen in central cord syndrome. The reason I asked you this is because it is a very, very common misconception. So don't feel bad that you answered that. Uh, that's the reason why I asked you that, because logically, if you have a hyperextension injury, you're probably thinking, oh yeah, the posterior part is injured, right? But it's most likely central cord syndrome, and it's most commonly seen in elderly population with already degeneration of the cervical spine. Okay, so let's go back to this slide. So this is the central cord syndrome. And what happens is if your level of injury is here, this also depends on how badly the person is injured. So there's loss of movement and sensation over here and incomplete loss over here. Obviously, it depends. Like if it's really, really bad, you can have complete loss below the lesion as well. And I want to talk a little bit more about this slide. I'm going to spend a little time over here. So you have to know what causes it, because most likely what they're going to do is they're not going to give you like this picture, probably. They're going to tell you the etiology, and then your brain has to go to there. So now when I asked you that question, like logically you're like, okay, it's probably posterior, but now you know. See, now you know it's like it's central cord syndrome. Other things that can cause it is cervical spondylosis. If they want to make it really easy for you, they can be like, sure, the elderly patient already has cervical spondylosis and then has a hyperextension injury. But that's kind of making it a little bit too easy. It can also be seen in syringomyelia, disc herniation. What the patient will present with is, like I said, this sort of scenario where at the level below the level of the injury, there'll be loss of movement and sensation. Um, and loss of bladder control can also be seen, spared sacral sensation. Don't go too much in the depths of what is preserved, like they'll have to say, oh, pain and temperature are preserved. But I feel like that unless you're like really, really good, you can memorize all of them, but I think it's easier to just memorize what is lost. And you can get most of the answers if you know the etiology and you know what's lost in that sort of uh, syndrome, you'll just get it. And all of these need an MRI. Okay. I mean, you can diagnose it clinically too, but like if they ask you investigation of choice, going to be MRI. Brown-Sequard syndrome, you guys already know. I'm probably mispronouncing that, but I've always pronounced it as that. Hemisection of the spinal cord, you guys have studied it quite a bit, I think. Very, very common. It's unilateral compression of the spinal cord, basically seen in trauma. So it can be anything. It can be like somebody stabs him, but only on one side, right? It's pretty easy. You have element signs and loss of all sensation at the level, and Babinski's kind of be positive below the level. Um, Very likely to be tested because it's so easy, right? Like it's just a unilateral compression of the spinal cord due to anything, right? It's like probably the easiest syndrome. Then anterior cord syndrome, that's if you think about it, it's kind of difficult to have an anterior injury if you look at it that way, because your patient is like this, and the anterior part of the spinal cord is pretty much protected. So you have to get really creative to sort of have that syndrome, which is why the number one cause is just the occlusion of the anterior spinal artery, which is like the easiest thing, right? And can be caused by hyperperfusion, iatrogenic, obviously, if you're doing like a surgery from the front, like an aortic surgery, obviously that can happen. Arteriosclerosis causing occlusion again of the ASA. What you see over here is again autonomic dysfunction, which is seen earlier, and then later on you can have hyperreflexia, which is very typical. It's the only syndrome which has hyperreflexia, but if you already know what region you're looking at, you probably get that you'll see all of these things. Again, really rare to see this because the etiology speaks for itself. You know what I'm saying? Again, you have bilateral loss below the region of pain and temperature, but again, like I would kind of like a lot of people like try and remember, oh, when is it lost? When is it still there? I would just say, just remember the general clinical features. Posterior cord syndrome, it's seen in posterior artery occlusion, then subacute combined degeneration of the spine, multiple sclerosis, Friedreich ataxia, which is very classic. They probably won't ask you this, but your patient will be on a wheelchair. Patient cannot walk. And really, really intense syndromes and diseases. And classic finding is the Romberg sign, which basically means I should probably put a picture here, but yeah, you guys know like Romberg sinus positive, frequent falls. The patient probably has to get up on himself. You know what I mean? Like he will have if it'll be a pediatric patient and he's like he has to like try and get support from his own body to sort of get up. So um and obviously you have to rule out syphilis because of this guy. So, really easy if you look at it like in a sort of etiological sense, just know what causes what and what is lost and what. Um, don't get too caught in the weeds of like trying to remember what is spared. Just know the basics, and it's pretty easy. You guys already know if you have hemisection of the spinal cord, it'll only be seen on like one side because the spinal cords sort of cross. And yeah, apart from this, a lot of the things you do have to memorize, but try not to try and like make connections like um you know um try and kind of have a patient in your mind. Like if you look at the central cord syndrome, try and remember the patient that I gave to you, like Mr. Brown. He has like a hyperextension injury. He already has some sort of spinal degenerative disease. It can even be like a Mrs. Brown with osteoporosis of the spinal cord, right? It can be of the cervical spine. It can be anything. So yeah, so that was a bit about this. A lot of people get like overwhelmed with the spinal cord syndromes, but don't be because they're pretty easy. I mean, especially if you just stick to the etiology and then know according to that what happens and what you see, it'll be okay. Um, the last two syndromes that again a lot of people find a little bit daunting are Cauda-Equina syndrome and the conus medullaris. So, as you guys know, it's like the end of the spinal cord, right? And it's called Cauda-Equina because it kind of like splays like a equina is horse, so it looks like a horse's tail. Conus medullaris is like it looks like a cone before it sort of spreads, so that part is affected. What you'll see in Cauda Equina, again, don't skip this because you think it's too hard to memorize. It's actually not. And I'll tell you why. Because in Cauda Equina, you basically have to remember this thing. And they probably will give you this because it is the easiest way to distinguish between these two. In practice, too, if you're like an IM resident, you will be looking for these guys. So if you know that the lower part of your spinal cord has been injured, a patient's lower part of the spinal cord has been injured, you're gonna want to look for bowel and bladder dysfunction, right? So in conus medullaris, it's the early onset of those symptoms. So for example, there'll be um uh, a Mr. I'm running out of names here, Mr. K. He will come with an injury or something like that, and he, he's completely stopped peeing or pooing, right? You're looking at conus medullaris. If you look at another patient, he's fine, but he has severe radicular pain. It's usually unilateral, so it's only on one side, and you have that classic saddle anesthesia. Okay, so maybe it'll present like with ED, like erectile dysfunction or something like that. And because Cauda Equina, like this is how I like to remember it, because the equina part is like a horse tail. It's more like it's not symmetrical as a cone is. Everything is asymmetric over here. So even the pain is not symmetric, it's unilateral. The weakness is also not, symmetric. Versus the conus medullaris, if you look at it, a cone is like more structured. So I like to remember like it's symmetrical like that. And again, over here in the Cauda equina, you'd have hyporeflexia. In conus medullaris, you'll have hyperreflexia. Does anybody remember any other syndrome that I discussed on like the previous slide where you have hyperreflexia? Because it's quite interesting, like the hyperreflexia part, because you think that if like something is injured, you'll get like loss of reflexes. It's pretty important to know when you see hyperreflexia. Does anybody remember any syndrome on the previous slide that also causes hyperreflexia? I'm just gonna go there maybe.
The anterior cord syndrome.
Yeah. Um, Yeah, I think somebody else was typing it too. Oh, okay. Um, so central cord syndrome, it does not cause hyperreflexia. Um, but then again, like you guys just you can take a screenshot of this. I'll like share this probably on the Telegram group too. Anterior cord syndrome and conus medullaris causes hyperreflexia. Okay, so if you get a question where your patient has hyperreflexia, those can be the only two options. And if you're really lucky, only one of them will be the there in one of the options. Okay. Okay, now this slide is my favorite slide in my presentation because they love asking you images. And I think a lot of people don't study them for some reason. And so you guys will know. These are labeled, so I'm not going to ask you, but does anybody know what you're looking at in this picture over here?
Multiple? Wait, no. GBM? No.
Don't be afraid, just, yeah, just like,
Aneurysm?
what?
Aneurysm?
No, because it's so like, it's like kind of outlined. This is actually a trick question. Everything else is kind of like a bleed over here. This is the only guy who's not a
The
bleed.
one with the butterfly lesion.
Yeah, exactly. What is that? Yes, glioblastoma. Very good. Everybody clap for, I want to say your name right. Is it Mami? Fana India. Oh my gosh, I think I just butchered your name. But
Yes, Mam Fana.
okay, Ma'am Fana. Okay, very good. Yes, butterfly lesion. That's perfect. Okay. So good job there. Anybody know what this guy is? And the kind of slice that I'm taking in this picture kind of is like a hint. Anybody know what this guy is? Look at the part of the brain, right? This is the anterior part. This is the nose and the sinuses. Where is the bleed over here? This is like very easy. If you guys got if you guys got this guy, you probably get this guy. Okay, I'm gonna leave that then. Maybe we can come back to it later if you guys think about it. Oh, somebody's written something in the chat. Medulloblastoma. No. But I see why you say that, but it's not the medulla. We'll come back to it, okay? Um, so you guys know this. EDH is a biconvex lesion. Like you know this. Banana shaped lesion is a subdural hematoma. Very, very easy. Okay. You guys should be like, if somebody wakes you up at 4 a.m. and shows you this picture, you have to know it's EDH. You have to know this is subdural. And this is just a normal contusion over here that you guys can see. Particular hemorrhage, they're probably not going to ask you, but sure, it's just included here. Intravesicular hemorrhage is seen over here, and this is an SAH over here. Again, like they might or might not ask you. If they're gonna ask you a SAH, I think it's gonna be like a bigger sort of lesion. It's kind of like small, but yeah, I mean these two you need to know definitely. This is a little bit difficult, but you guys know it. I'm going to give you a scenario to kind of help you out with this. So you have 29-year-old Samantha. She's driving from Alberta to Saskatchewan on Canada Highway 1. And she's speeding like a lot. And she sees a deer on the road and she swerves, okay, to try and not hit the deer. And when she swerves, she kind of like hits her head on um the steering wheel a little bit, and then she's like, oh my gosh, that was like crazy. And but she keeps going. And then after a while she reaches the on the way to Saskatchewan, she reaches the Moose Jaw Hospital where I'm going to be a resident. And I'm like, okay, I need to do like a CT scan of you because you seem a little bit confused and disoriented. And I see this. So what should I be thinking of? it's diffuse axonal injury. Okay, this is, I know it's like kind of like a difficult question, but if you see like weird lesions just randomly everywhere, it could also be diffuse axonal injury with petechial hemorrhage. Like this probably is a petechial hemorrhage, honestly. But yeah, just don't be confused, especially if they give you a scenario where the patient has been in like an an injury where, it's something like the one that I just discussed, or, she's speeding a lot and then she suddenly stops, something like that, or she's like in a roller coaster that accident or something like that. You're going to want to start thinking about diffuse axonal injury. Okay, now I want to come back to this. So this slice has been taken like over here, which is in the level of the cerebellum. It's cerebellum, cerebellar hemorrhage. And so you're going to see this classical signs of like ataxia. Everything that the cerebellum is basically responsible for is going to be all wanky. What do you guys think is happening over here? This is the last one. I will let you off the hook a little bit after this one. Like, what is huge over here? Like, look at this.
The ventricle.
Yeah, exactly. Oh, we have something in the chat. Yes, ventricular enlargement, correct. So this can be seen in a lot of cases. I think I have some slides on this, but you have the classical wet, wacky, wobbly guy. And I think the next slide is kind of okay. I'm going back to this. Somebody said something in the chat. Chiari manifestation. So that they will probably give you another slide of the Chiari manifestation, like, and they'll probably give you like the thing classically like coming over. I think it's kind of unfair to diagnose Chiari manifestation, like the malformation over here. Let's come back to that because I do have some slides on that. So, yeah. Okay. Okay. Let's see what the next question said. I wanted to make this one more interactive, but don't think like if you can't answer, it's totally fine. Like I meant most of these questions I meant for you guys not to get. And so you'd make a mistake in the class and you won't make it on your exam, right? So you have a patient with headache and visual dysfunction, which are classically seen in subdural hematoma. It can also be in another case. Okay. I'm just gonna let you guys think about that a little bit and go back to my ventriculomegaly. So in ventriculomegaly, it can be caused by a number of things. The most easiest, it could be like completely like idiopathic too. Idiopathic ventriculomegaly does exist. It can also be severe hypertension. So the wet, wacky, wobbly that I was talking about is that you have wet is for increased urination, so hyperurination. Wacky is confusion, and wobbly will be ataxia. So that is what this image is. They give you this image in your exam, and they give you like the wet, wacky, wobbly guy. You guys know something wrong with the ventricles, and that's it. You guys know it. It's not a bleed anywhere or anything like that, so don't get confused. I think you guys did really well. I was like really proud that you actually got this, even though I put this image with a bunch of like bleeds. You know what I mean? Okay, so let's get back to this one. So this is like if they ask you this question or something around this question, it's gonna be like a severely difficult question according to me. But you'll get it because we'll discuss it now. So what happens in something that might look like a subdural hematoma is this thing called pituitary apoplexy. The only thing, so like don't get overwhelmed. Okay, we're gonna talk about this. Subdural hematoma is going to be very easy because it's going to be a patient with trauma. It's going to be, headache. It's going to be probably, visual disturbances. But if this patient also has severe hypotension, if she is slightly more complicated than a subdural hematoma, and they're not going to give you a picture of like they're probably not going to give you like an image in this scenario. But if she has like, again, think of severe hypertension. Your subdural hematoma patient, like the intracranial bleed that causes the subdural hematoma, is not going to be enough to cause hypotension. So don't even go there. Okay. It's not gonna, you don't even think like, oh, of course she's bleeding, of course she's gonna be hypertensive. If your subdural hematoma is big enough to cause hypertension, your patient is probably dead. Okay. So what is pituitary apoplexy? It's basically intrapituitary problems, and you will get everything that the pituitary is sort of responsible for is going to be in a mess. Okay. So what that means is if you get a neuroimaging on this, you basically just see your pituitary enlarged, which would be pretty difficult for you guys to know what the pituitary looks like and stuff. But if you see like, if you go back to the imaging and you see like over here, there's something that's really huge and whitish, especially on T2 weighted. Is going to be pituitary apoplexy. Again, this is going to be a difficult question on the MCCQE if it does show up, but you're going to get it because we discussed it, right? The treatment over here, again, very important, is that is glucocorticoid replacement because the pituitary is responsible for secreting ACTH. And in an acute setting of pituitary apoplexy, it might even lead to adrenal crisis. So if you see a patient that's like really confusing you in this sort of scenario, like it's looking like a subdural hematite, like the symptoms are subdural hematoma, but like you're seeing other symptoms of like really severe symptoms, like of hypertension, of adrenal crisis, of like especially vision changes that are completely out of proportion, it's probably going to be like this guy. And why is there bitemporal hemianopsia? Does anybody know? Anybody can take a guess. Think of where the pituitary is in your brain with regards to other structures.
The optic chiasm.
Yes, exactly. So you guys already know it, right? It's already like there, but you just have to make that connection. The pituitary is sitting right there. So if it's enlarged or if there's like any problem, it's going to press on it and it's going to cause bitemporal hemianopsia. So if you have a patient, they can even start the question saying, patient comes in with bitemporal hemianopsia, severely hypertensive, and they might even give you like an adrenal thing, you know, like the electrolytes are all off. You're looking at your electrolyte chart in the exam and being like, what is this? It's something wrong with the pituitary, okay? And speaking of, I wanted to tie in acute adrenal insufficiency or adrenal crisis. You guys already know this, right? It's going to cause hypertension, shock, nausea, vomiting, abdominal pain. The classic symptom of like adrenal crisis. Pituitary apoplexy is one of the things that can cause adrenal crisis. The other things are obviously adrenal hemorrhage or infarction, illness, injury, and stuff like that. I just wanted to tie it in so you guys remember what acute adrenal insufficiency is and how you treat it. And obviously, how you treat it is you give hydrocortisone or dexamethasone, right? Same thing with pituitary apoplexy. You just do glucocorticoid replacement. So yeah, now you guys know a really difficult question they might ask you. The next thing I wanted to touch upon is foosh, something that they might ask you. Is let's say this is our patient, Mrs. Ling. She's Asian because in Asian populations, osteoporosis is seen slightly more frequently. Because of dietary sort of restrictions that some Asian populations have. She has fallen outstretched arm. What can be seen in this patient? So, like the picture says, if she falls like this, very easily you can get a scaphoid fracture, and it's really fair for them to give you an X-ray for the scaphoid to be broken. But if you look at it and you're like, oh, I don't remember what this this thing is, this carpal, you're like, just remember scaphoid fracture is seen in fallen outstretched hand. So it's most probably going to be scaphoid. And now you guys know what it looks like too. It kind of looks like, that's why it's called scaphoid, because it has this shape. It can also be distal radius fracture or Colles fracture, very, very typical deformity that you guys already probably have heard of. You can have an ulnar styloid fracture, again, very common. You can have a supracondylar humerus fracture, and then depending on how the fracture is, you can have nerve damages. You guys already know this. Ulnar nerve is responsible for this part of the hand, median nerve is this part. So she can have like paresthesia, check for distal pulses, and again, she can also have posterior glenohumeral dislocation. This question can very also be easily asked in the neck. Now, what they're gonna do in the neck, I don't know how many people are IMGs over here, how many are CMGs, but the neck is only again for IMGs, but CMGs also have OSCEs that they have to pass though. So what they're gonna do is they're probably gonna give you a patient who's fallen and outstretched. Obviously the patient's not going to be somebody who has a fracture, but because of the history, you're going to know what it is. So for example, let's take the supracondylar humerus fracture guy. Okay, so let's say you have Mrs. Ling comes to you as an OSCE patient, and you introduce yourself, all of that, and you say, okay, can you tell me what happened? And she says, oh, I was carrying my groceries and I fell. Okay, and this will happen to you in like real life too. They're not gonna tell you I fell on an outstretched hand. Okay, they're gonna make your life a little bit more complicated than that. You have to say, can you tell me how you fell? And this is really important in the neck, because if you don't ask this question, you basically don't know what your etiology is. Okay, you don't know it, so you have to ask it, because she's not gonna tell you unless you ask. She said, I fell forward, and then you say, oh, where did you hurt yourself? Did you fall on your elbow? Because then it's completely different etiology, right? Or did you fall on your hand? And then she's going to be like, I fell on an outstretched hand. And then you're like, okay, now I have to think of 1, 2, 3, 4. That's it. Okay, you have narrowed your diagnosis to 4 things versus so many other things that could have happened, right? If she fell on her elbow, you're probably thinking of an actual humerus fracture. And so yeah, so this is how you narrow your diagnosis in the neck. And I do want to have more neck sessions, because my residency does start in July, and I'm probably going to be really, really busy in July. But yeah, I just want to tie in a little bit of the neck in these sessions too. So you've already done that. Then in the neck, you're going to ask her, because it can be multiple fractures too, right? And if you miss out on one fracture, you're going to miss out on marks too. So you ask her, where does it hurt? She's going to say, okay, it hurts over here, let's say. You have to ask her, does it hurt anywhere else? She might not tell you. And even if she says no, you have to go in your examination and actually palpate this part of the hand and say, tell me if it hurts. And then if she's going to be like, ow, you're looking at a scaphoid fracture. Okay. So this is how you get marks where it's actually, and honestly, it's very fair, because it happens in real life too. If somebody's humerus is hurting a lot, it can actually mask the pain that happens in that she's experiencing in the hand. Okay, so maybe we'll do a mock on this later, but very, very important is to diagnose all that is wrong in the patient in the neck, and it's probably going to be more than one thing. Okay, can anybody answer me this question? Is posterior dislocation more common, or is anterior dislocation more common of the glenohumeral joint?
Anterior.
Yes, very good. So do you know how an anterior dislocation patient is going to present to you? Very, very classic. Like, how will he come? How, like, Mrs. Ling is going to come, like, she's going to be holding her humerus like this, and if her scaphoid is hurt, she's going to be like, holding it like this. Anterior dislocation, if this is the one that's injured, he's going to be like this. And it's even in your neck, if you see a patient coming like this, it'll literally be like this, and he's like kind of coddling his arm like this to try and keep it stable. Because if it's dislocated anteriorly, the only thing that's sort of stabilizing it is your own like other arm and your own body. So he's going to be like coddling his shoulder like this. So then you have to think of anterior dislocation. And this happens in real life too. Like I've seen patients, they literally come like holding their arm like it's a baby because the only thing that is supporting it is your own other hand. Okay. So this I think this is the last slide. So the most common shoulder dislocation, as you guys answered, is anterior, and it's caused by a blow to an externally rotated and abducted arm. So basically, it's like this. So now this can be a lot of scenarios. You basically need to just know that it's a blow like this. So in your MCCQE, if they want to confuse you, they can be like, Dorothy was playing tennis and a ball struck her when she was, just about to serve or something like that. Or somebody was surfing where your arms are sort of externally rotated, abducted away from your body, and she fell on like the surfboard. Basically, it's not going to be foosh, and it's going to be the arms are away from the body. Okay, and that's what causes anterior dislocation. How will it present? The deltoid will obviously be flat, and that is simply because it's dislocated and it's like this, right? There'll be fullness of the anterior axilla, obviously, because it's come out like this, right? Protrusion of the acromion, again, it's just because this is this part of the humerus has come down, and the acromion it's sort of protruding just because of how the anatomy is. And the arm is externally rotated. Just remember this, okay? And very, very important is the axillary nerve injury is the most common injury in the anterior shoulder in this scenario. So they can ask you this in the exam too. And does anybody remember what muscle the axillary nerve, what like the main muscle of the axillary nerve supplies? You guys remember any anatomy? Or any muscle that the axillary nerve sort of innervates. You guys know where it goes, right? Like the axillary nerve. Okay, because this is the last slide, I can leave this as homework for you guys. Okay, somebody sent it in the chat. Yes, deltoid. Very good. And maybe as homework, you can say like, what are the other things that the axillary nerve does and what is seen in axillary nerve injury? Because like I said, anterior dislocation of the shoulder is the most common dislocation that's seen. So yeah, that was the end. I think that was about an hour. I guess I can like stop the recording. Maybe I'll do it later. I don't know. So this isn't. Oh yeah, no worries. This isn't the end of surgery, obviously. This is just things that I thought were difficult to weed out. There's like a lot in surgery, and I don't think we can like fit it in just 1 hour. They're really basic things that you just have to like learn. I probably won't go over each and every one of them, but I do want to have a second surgery high yields thing. And in these classes, I kind of want to focus more on like conceptual things. So like, and things that people, because it is conceptual, they kind of skip like like the spinal cord syndromes and stuff like that.